Welcome to today's webinar, Unlocking the Key to Health Equity in the Revenue Cycle. This is Rosalind Lewis, HFMA's Technical Analyst, and I will be moderating today's session. Now, it is my pleasure to welcome today's speakers. Scott D'Entremont is Chief Revenue Officer at Parlance. Scott has a technology career that spans 25 years, with 20 years in executive management. As founder CEO of NetSpoke, Scott grew the company from 2 people to 120 and an annual run rate of more than 20 million. Scott has worked with many health systems, large and small, to facilitate easy, equitable patient access, optimize business operations, and improve caller and agent experience. Gina Stinson has over 30 years experience in end-to-end revenue cycle services. She serves as Senior Director of Revenue Cycle for HealthRise, a Southfield, Michigan healthcare consulting and revenue cycle services organization. Gina has worked with various organizations and delivery systems such as MD Anderson, HCA, Conifer, Enthrive, and Aetna. She is most passionate about patient access and denial prevention, as well as sharing her knowledge and expertise with others in pursuit of developing critical thinking, as well as key management and operational skills in tomorrow's revenue cycle leaders. With that, Scott, I'll turn the presentation over to you.
Thank you. Good morning or good afternoon, everyone. Thank you very much for attending. Looking forward to sharing some information and also to hear your feedback about how you think about how health equity and how it's affected you, and maybe if we have time, even some of the things that have happened within your organization that have been positive or negative around the topic. Our objectives today are 3: to learn about health equity and health disparity, understand how healthcare and financial leaders can contribute to solving health equity and make it a bigger part of the way people think within organizations, and to explore innovative solutions in support of improving health equity. So it starts with really thinking about, what are we talking about when we're talking about health equity? How do you define it? And so we thought we'd start there, and you see your first poll, and really, many people think about it in many different ways. Is it just that everyone has access to care? Is that equity? Or is it more that there's some thoughtful approaches in place to deal with the fact that different people have different abilities to access different systems or different information within the organization? And ultimately, can everyone get the same outcome from their interaction with your organization?
Interesting. All of the above.
I think so.
Yeah, great feedback. So as we dive into health equity, actually, when exploring health equity, what we're looking at is ensuring that patients are positioned to achieve like outcomes. And so we're going to dive into that more this afternoon. And when we wrap it all up today, hopefully you'll have a better understanding of health equity and what you can do as a revenue cycle leader to support the development and implementation of health equity at your site of service. All right, so let's dive in. So the World Health Organization defines health equity as the absence of unfair and unavoidable or remediable differences in health among population groups defined socially, economically, demographically, or geographically. So we can see that the World Health Organization is looking at differences and differences by group. Now, conversely, if you look at the Centers for Disease Control and Prevention, their definition of health equity is to ensure that everyone has the opportunity to be as healthy as possible. And their perspective is that this can be addressed by making sure everyone can maintain and manage physical and mental health, which requires easy access to information, affordable testing, and medical and mental health care. So when you're looking at the definition from the CDC, they're looking at the opportunities for that individual. Let's bring it home a little closer and let's look at what providers are saying. So a provider at Yale Medicine said, equity means people get what they need to achieve the same results. It's more about outcomes. So for us, as we go through the exercise today, we are going to focus on that, the individual and the respective outcomes. How can we help each person achieve the best outcome for them? On the screen is a visual representation. You've probably seen that. It's often used to illustrate, equality in various aspects. So what we're showing here is that equality says, let's give everybody a box of the same size. That's going to help that individual see over the fence and get what they need, a view of what's on the other side. But health equity digs a little bit deeper, and it says, am I giving the person what they need to be successful based on their individual situation? So if you look at the image to the right, it's showing you that health equity is for the taller person there. They can see perfectly over the fence. They don't need anything extra. For the person who's a little bit shorter, they need a bigger boost. And so they've been given a couple of the boxes to help them see over the fence. And then the third individual is given a ramp and is lifted up even higher because that's what that person needs. And then collectively, you can see that everyone is able to achieve what they need to have the same outcome, seeing over the fence. Now, I recognize that this is a much easier illustration than what we experience day to day in healthcare, but it does lend itself a good visual. And I would encourage you to leverage this whenever you're educating folks at your site of service about what the difference is between treating people equally versus ensuring health equity. And remember, we said that for the purposes of our presentation, we're going to focus on health equity, meaning that we're providing for the individual what they need to achieve the desired outcome. So to do that and answer the question, we really have to understand what feeds into health equity. And a key root line or a root problem to health equity is health disparity. So what is health disparity? The National Institutes of Health define health disparity as the differences in the incidence, prevalence, mortality, and burden of diseases and other adverse health conditions that exist among specific population groups. It's important to note, however, that not all health differences are health disparities. So let's dive into that a little bit more. So there are 6 areas of health disparities. So we're going to call these areas of health disparity. You have the economic stability of the individual, which speaks to employment, income, expenses, debt, medical bills, and support. You have their neighborhood and their physical environment. So here we're drilling into housing, transportation, walkability, playgrounds, parks, where they live geographically, their zip code demographics. Then you have education, which speaks to literacy, language, early childhood development, vocational training, and higher education. Food. We have food security and access to healthy options. Then community, safety, and social context. Here we're looking at social integration, support systems, community engagement, stress, exposure to violence and trauma, and policies and justice. And then moving over to the last column, we have healthcare systems. That's us. We're healthcare financial management. And so we're here from the perspective of health coverage, provider and pharmacy availability, access to culturally appropriate and respectful care, and the quality of care. So collectively, each 6 of these areas feed into the health equity of the individual. Do they have everything they need or not to get care and services that will achieve those optimal outcomes for that individual? So from there, you're looking at, mortality, morbidity, life expectancy, their healthcare expenditures, health status, and their functional limitations. Going back to the graphic that we looked at, one of our 3 people needing to look over the fence, one had a physical limitation. And so we know that that person needed a little bit more, needed a ramp a little bit higher to get what they needed to have that same outcome, seeing over the fence. Again, simple analogy, but it really paints the picture of the differences that each one needs to have optimal outcomes. So whenever we talk about being financial leaders in healthcare, access always comes to mind. Scott, would you like to poll the group?
Sure. Really, it comes down to people thinking about what role the health system can have to help directly advance equity. Can you bring new technologies to bear to push things forward, or are the problems sort of too big and outside of our control to really make a difference?
Yeah, great question we have on the screen here. I'm curious to see the answer from our respondents. So with respect to health equity, Scott, has there been anything of interest that you've seen over the last 6 months related to health equity?
Yeah, one of the groups we work with is NYU Langone in New York, and they're just dealing with, they're a very large system, and they're dealing with so many people that they felt in order to manage the vaccine process that they needed to bring it all online, and really found that that didn't work for everyone. In fact, even when they would send out text updates to some of the people about, where you might be in line, relative to eligibility, every time they sent some of those communications out, their phone volumes would still rise, and then that would degrade service for everybody. Wow. So it was interesting because they thought they could leverage technology in a way that was going to smooth it out for everyone. And then they found that they were actually kind of creating a hurdle for a certain part of their population, just as other people preferred it and could really thrive in that environment. It really wasn't one size fits all.
Oh, absolutely. And we're going to learn more about that too as we venture into our presentation here. But looking at the polling response, 50% of the audience agrees that technology will help the health equities problem that we're faced with. 36% strongly agree, 13% somewhat agree, and 1% disagrees. Interesting statistics there. All right, let's keep going. So you just hit on something, Scott, that I thought was really important when you were talking about the provider that you had worked with previously, because
Right.
They thought that implementing a new solution was going to solve all the problems. And ironically, a lot of people thought that whenever we deployed telemedicine as a result of the pandemic, I mean, it was there, it's been there for some time, but the pandemic really brought it to light. But what happened as it rolled out and what providers found is many of their patients didn't have the technology to utilize telehealth. They didn't understand how to use the technology. And so by not having it or not understanding it, it hindered people from successfully working with the technology. And so what providers felt as a result is that the safety of many of their patients were compromised because they were still having to come into the office, whereas if they would have been able to leverage that technology, they could have been safer just staying at home, working with the provider through that technology. So we can see right here that technology made a difference. It helped, but it opened up the question to, did it solve all the problems? And under health equity, we would have to say, unfortunately, it didn't solve all the problems. So as providers, we have to become even more creative and ask ourselves, what can we do to help our patients? So I want to share with you, this is a real person, not the person displayed on the screen, obviously, but Sarah is a real person. She lives out in rural New Mexico. And with Sarah's story, we're going to talk about disparity and the difference. Because remember, the World Health Organization was focusing on the differences of groups. Well, there are some differences that aren't actually disparities. So we really need to hone in on what is a disparity versus a difference, and how does that impact the way that services are made available to individuals. So we have Sarah here. She's a mother of 4, lives in rural New Mexico. Okay, so she has 4 kids. That's a difference. Not everybody has 4 kids. She lives in rural New Mexico. So you ask yourself, rural New Mexico. Well, think back to what we just looked at in the areas of health disparity. The neighborhood and physical environment lends itself to a disparity. So the fact that she's in a rural area could fall under a disparity. Her family's uninsured. That actually hits 2 of those 6 elements we looked at. It hits economics, and it also hits her providers and what her coverage looked like. She has no coverage. So she is compromised from 2 perspectives right off the bat. She works 2 part-time jobs. So again, that falls under that economic umbrella. Her family's not eligible for Medicaid. So that impacts both economic and the coverage umbrella that she has. She's blessed that there is a new all-in-one grocery, household retailer, pharmacy, and a PCP office that has opened up nearby. But the health system that supports that PCP's office, it's 2 hours away. So access to care falling under that health system's umbrella, she's having some disparity there. For Sarah, all of her children need an annual wellness visit. Okay, great. Let's get her children taken care of. However, she calls that PCP's office and they have limited access or no consecutive appointments. I run into that routinely working on the front space in healthcare. Working with large physician groups, we often find that patients with large families have to schedule multiple appointments on different days to get the care that they need, because those consecutive appointments are not available, or they're limited to the number of people that they can bring to an appointment. Like if you have a pediatric appointment, they only allow 2 children at a time, for example. So because of this, Sarah is forced to take multiple days off to get the appointments that she needs for her 4 children. So this is a blend of, coverage and access being a challenge for Sarah. And then also it hits on the economic, because here she is already uninsured, working 2 jobs, and now she's having to take an additional day off to cover the appointments for her family. So that just compromises her situation a little bit more. Not to mention that appointments are expensive. Let's face it. It can be expensive when you don't have insurance. It can be expensive when you do have insurance. It's all a matter of perspective. So what happens to Sarah, because of her large family and her needs, she often forgoes the care that she needs because she's trying to get her children taken care of. So in this scenario, is this family truly getting what each member of the family needs to have optimal outcomes? I mean, the mother's clearly working on trying to drive the needs of her children, but at her own expense. So it could be easily said that we are looking at a very disparate situation for Sarah and her family. So let's connect some of the dots here. We looked at the areas of health disparity earlier, and you could tell that It's the economic and the social elements that really hit home and drive disparity. I mean, think about some of the things we just looked at. If your neighborhood is one where you can't even walk around in your neighborhood, how many times do you go to the doctor and they say, you need to walk? Exercise is good for you. Just start walking. Well, if you live in a neighborhood where that can't happen, then that creates a disparity for you and the outcomes for your health. What about food? How many times have you gone to the doctor and he said, they'll tell you you need to engage in a healthy lifestyle, eat more lean meats and vegetables and, different things like that. I don't know about you, but for me, I try to eat healthy, do a lot better than I used to, I'll say. But it's expensive to eat healthy. So I can see how that can be a challenge for individuals who are faced with those types of, food insecurities and access to healthier food options. Economics, we just saw in Sarah that, she's not insured, she's got a family of 4, she's working 2 jobs, so clearly creating significant disparity. So whenever you're thinking about the situations within your healthcare centers, your hospitals, your clinics, whatnot, it's these two, the economic disparity and the social elements and disparity, where we really can make a difference to solve the health disparity issue that's feeding health inequity. Because remember, our goal is health equity. So we've got to eliminate these disparities to create a more equitable situation, which is an individual outcome. We've already defined that earlier, for what we can achieve with each individual. So the Centers for Disease Control has, this a lot of really great information on health equity. I would encourage you to explore their website along with several others mentioned here today. But key to paving the road to health equity from their viewpoint is ensuring that you have a strong organizational infrastructure that can support various programs, measurements, and policies related to driving health equity. So you may be asking yourself, I work at a hospital. What can I really do to make a difference to solve for this health equity challenge that's ahead of all of us? Well, there are solutions out there. And what I would encourage folks to do is to start with information that's already available. Many hospitals out there conduct periodically a community needs assessment. So I would start there. Does your hospital conduct a needs assessment? Who conducts it? What's done with that information? Leverage data in your state. There's a lot of local and state data available that may provide a lot of the answers that you're looking for to help you solve the equity challenges that are in your area. You may want to look at focus groups, bringing patients in, members of the community in. And you may be asking yourself, wait a minute, all of this sounds way bigger than healthcare. Me as a revenue cycle leader, where do I come into this? How do I really fit into the equation? Well, we've already talked about a couple of those examples. Take Sarah, mother of 4, trying to get appointments for her family. Maybe examine your policies related to appointments for large families. Start there. Simple fix. Well, I say it's simple. Sometimes some things are easier said than done. I recognize the politics behind some things, but looking at the pieces, a lot of the members on your team already know a lot of the barriers that your patients are faced with. But you know what is hurting all of us from driving success related to the things that we're learning and we're hearing every day from our patients? We're not capturing that information. We have no way to say, oh, Ms. Smith called about X, Y, and Z, and this is an issue for her. Because these pieces of information that are critical to identifying needs and opportunities within a service area aren't being captured. They're not being reported. And in order to drive health equity, we have to know what's needed, where it's needed, and who we can partner with to help achieve a solution. So it's not necessary that we ourselves have to solve the problem, but we have critical information that can contribute to the solution. And we have the ability to engage our local communities and partner for solutions. So it's about getting, working smarter, not harder. The reality is, no matter what we do as a healthcare provider, funds are going to be needed to help this endeavor. So I would encourage each and every one of you to explore those funding options. How can you help your community by partnering with others? Maybe there's a local community you can get a grant from. Maybe there's a government grant. Who knows? A lot of things are out there. You just have to explore what's available, what's needed, and how you can connect all the dots. But I believe that all begins with the data and what we know. So we're going to move into how we can eliminate disparity and create health equity. And it really is getting that understanding as a revenue cycle leader of what do we mean by access? We've talked about access. We've looked at the 6 areas of health disparity. We saw on that list that there was an area specific to the healthcare system and that access to care was an issue. But when we talk about access to care, what access are we talking about? You've got physical access. Can a patient physically get from their home to their appointment? So you run into that transportation. Remember, that fell under the 6 elements of health disparity. Transportation was in there. Or is it professional access? Is it just their ability to get an appointment and see a provider? Think about Sarah and her 4 kids. Were they all able to get in when the time was needed, that they needed to have their annual wellness? And what about Sarah? She just gave up on her own self because she didn't have what she needed to make that happen. Or is it technical access? So maybe you've got somebody who can get to the, has the ability to get to the doctor. They make it to the doctor, and then the doctor's writing them an order for an MRI. But pretend you're Sarah and you're 2 hours away from your health system. So is getting and accessing that care really easy? Is it going to be a hindrance for Sarah? Is that going to impact her outcomes? Or is it patient access? Like, the revenue cycle arm, us, what we do day in and day out. It's all of it. It's all of it. And we have to dive in, identify where the disparities exist, identify where we can make a difference. And that's how we can contribute to the solution as healthcare financial leaders in solving for this problem. And it's not going to happen overnight. And it's going to take a lot of collaboration and a lot of hard work, but it's the right thing to do for the patients that we serve each and every day. So within the revenue cycle, I would argue anybody that it truly is going to be our people and our technology that are our greatest asset to driving the solution to health equity. Again, you may be asking why. Why do you believe that, Gina? Simple. We have to identify the disparity. We have to know what the need is. And we have the ability to gather that information. Think about every conversation that happens in your hospital day to day. The conversations that your scheduler's having with the patient, the conversations your financial counselors are having with patients, your case managers, your social workers. Think about those complex psychosocial evaluations that your social managers are doing every day in the hospital. And And all of the information that's gathered, that's information that can help solve for health equity. Well, what are we doing with this information? Are we just entering it into a system and not really doing anything with it? Why would we do that? Why would we gather the information if we didn't use it? There are some people doing a great job gathering information, and there's other people who are challenged in gathering the information. Maybe they don't have the ideal systems to help them capture the information that's going around the hospital day to day. I mean, that's a real struggle that exists for some. But I still would challenge you to say, from my perspective, that it will be our people and our technology that will be our greatest asset to solving for health equity. So diving into that a little bit more and looking at disparity identification and data sharing, this is where things really open up. And this is where we as revenue cycle leaders have to acknowledge that this isn't our problem alone. This is a systemic problem. It's one that's going to take everybody to solve. And it's not just going to be the people within the confines of our system or our site of service that can solve for the problem. It's going to take a lot of collaboration with the community. It's going to take identification of all kinds of information. If you go back to the slide we looked at earlier with the areas of health disparity that can impact the outcome for the individual, I mean, it's huge. It's huge. Capturing that data and those disparities is going to be critical. The integrity of that data is going to be critical. So you have to ask yourself, I'm getting a lot of information. I'm hearing things over the phone. I'm talking to patients face to face. I'm writing stuff down. Well, a lot of that is data that then has to be translated and put into the system somewhere. So you want to make sure that with whatever you're doing, you're eliminating the risks for error so that your data is as accurate as possible. So therein kind of lies another struggle to the challenge as a whole. To be successful with health disparity elimination and to drive health equity, we're going to have to create partnerships and leverage those partnerships to drive real-time solutions for our patients in the communities that we serve. Do your current policies hinder health equity? So there are, a multitude of policies that drive the revenue cycle. Many people, for example, will have their take your self-pay policy or your financial assistance or charity policies. I mean, that's a good place to start. Are we setting up policies that make it truly a value for the community we serve, or are we hindering the community that we serve? Now, I get the fact that we have got to pay for the care that we provide. Providing healthcare services is not cheap. It's very expensive. I live and breathe it every single day. I know the numbers. So I know that that's going to be a challenge, but it's one we have to ask ourselves. Are we doing the right thing? Is it fair? Does it serve the end goal? If we are going to commit to solving for health equity, are we going to commit all in? Are we only going to commit a little bit? And that's going to be an organizational decision from entity to entity. Along the way, as we're working with all that we're doing to support health equity, capturing information, sharing information, it's that sharing part that's going to be critical, because it is vitally important that you share the information that you can with others. Because why put a burden on another entity to duplicate efforts when you have information that could support a project that they have based on the information you've gathered in support of those areas of health disparity. So if it's non-PHI data, information that can easily be shared, you've got permission to share it, why not? Leverage those partnerships and share information. And at the end of the day, when it comes to health equity and our solving for this problem, we've got to be able to measure it. We've got to be able to say, this set of the population identified these issues. Did we really move the needle for these issues? Or are we just saying that we did? So if we're truly going to solve the problem of health equity, we have to be able to capture what is disparate and what's happening today and how we drove change. Because remember, it's all about that individual and the needs of that individual. All right. So again, I'm going to hit this one at home again. How can we, as revenue cycle leaders, support health equity? I would encourage each and every one of you to think about your revenue cycle systems. We've got 3 spaces, front, middle, back. We've got over 20 functions across those 3 spaces. We've got over 60 individual tasks that are happening day to day to operationalize all of those functions. Start by looking at your time waste. What's slowing you down? If we're truly going to be patient-centric, we've got a lot of people out there who talk about being patient-centric, but to dive into health equity and to really be a different provider when it comes to solving for health equity, we've got to be holistically patient-centric. So lean out your process, get as much waste out of there as you can, maximize your technology, and use that technology to identify and capture those elements of health disparity that we can affect change within our local communities. Because it's not about solving for the world stage, it's about having a positive impact on your local community, because that's where the disparity is in the service, in your service areas. So that's where you want to look. And then leverage that data, identify any gaps, partner with any of those organizations that you can, and implement those corrective actions, either internally, if you've got a solution that'll fix one of those disparities, great. If not, who are you going to partner with? How are you going to solve the problem that your community has identified? Your consumers are saying, hey, I need X, Y, and Z to get the same outcome. How are we going to solve for that? Your patients are going to need you in this process. And as you're working through health equity solutions, they're going to have to believe that you care. Because when you start asking them questions and start capturing this information, you know how patients are, red flags. Why are they asking me this? What are they documenting this for? How is it going to be used? So your healthcare consumers, your patients, they need to believe that you care. And because you do, we're healthcare providers. We're here every day because of that patient. We do care. And so we need to ensure that we infuse that care and compassion for our patients, so that when we start asking questions to help better support them through the identification and elimination of disparities, they know that we're asking from a sound, safe, solid place, because we want to make a difference for them. Your providers, whether it's your physician providers, providers of service within the community, they need to know that you're partners and you're in it together, and you're going to work to solve the problem together, because you can't fix just one piece of it. If you're really going to drive the solution to health equity, it's going to take everybody, and that includes your entire community. Let them know what you're doing. Share that information. Partner with others in your community. There's a multitude of nonprofit organizations out there with a vested interest to help solve many of these health disparities that we've looked at. Going back to that chart that we looked at that had the 6 areas of health disparity, there's a multitude of organizations that you can partner with. And they may just need a place to meet and talk. It could be something as simple as that. But what are you doing to help that entity? Maybe they need stronger connections within the community to better leverage or position themselves to be of greater service to the community. You don't know until you meet them, ask them, talk to them. But if they have a service that can solve one of the health disparity issues, it behooves us to have those conversations. And then as you're going through this, you've got to have the buy-in from your employees, because who's going to be capturing that information? Who's going to be making sure that whatever needs to happen happens with that information, whether it's sharing data, analyzing reports, whatever the case may be, asking patients questions, who knows? It depends on how you are approaching the topic and the need at hand. But people are going to be critical to your success, and it's vitally important that we have a strong relationship with everyone, empower everyone in the solution of solving for health equity, and bring those solutions home. All right, so we have another polling question. Scott, I'm going to toss that back over to you.
So, we want to make sure that we don't make anything worse. I mean, and that was a little bit about my first story. There's been so much momentum towards the conversation that says, we need to move everything to the internet and meet people where they want to meet us. And while that's true, and those initiatives are vitally important to kind of meet with the evolution of kind of basic technology and the fact that we all effectively carry a computer around with us, many of us or most of us these days, even people at the lowest end of the socioeconomic scale will tend to have a smartphone. We don't want to forget the fact that other people are still, preferring to use the voice or some other channel. 91% of people agree that we don't want to make it worse. And I guess as we kind of go through, we can talk about some of the ways to have a balanced approach as we kind of continue on.
Absolutely, because there are technologies available that can help make the things that we've talked about today actually easier. All right, and perfect segue into our next category of technology. So we do have another polling question. I'm just going to read the question. Since technology will only be beneficial in eliminating persistent inequities in healthcare, if there is a solid data and planning behind the initiatives, these implementations will take a long time. Do you agree, somewhat agree, disagree? Yeah, so 42% and then 8% strongly say that they agree it'll take a long time. We're split 50-50 on this one, because obviously we've got a really smart crowd, because they know that there are other solutions out there that are easy to implement. So great feedback, guys.
People are saying it depends, I think, on this one. It depends. And I think they're right.
They're absolutely right. They hit the nail on the head. So I have to agree that one's technology and how it's used is going to be one of the greatest differentiators in driving health disparity identification and health equity achievement. And so by leveraging our people and our technology, our greatest assets, we will be able to make a difference. As a financial leader, we have to balance, and you know this as well as I do, those optimal outcomes in the interests and needs of our current patients with the financial health of our organizations. And the need for data to support this and a better tomorrow is going to be critical. Let's think about this for a second. I mentioned earlier that every day in the hospitals, we're talking to our patients. We're on the phone, gathering information. We're talking with our social workers, care managers, multitude of people. So a lot of things are being spoken. A lot of things are being said. What do you think about the idea of capturing what's being said and translating it into the data that you need? Could that happen? Anything's possible. So how can we make it easier for people to access care? Scott, what do you think?
Well, we think that not sort of moving past the way that everyone, not so quickly moving past the way that everyone has interacted with health systems forever, which is kind of the voice channel, if you will, picking up the phone and calling is an important part of not creating more disparity. In many of the communities that we have experience with, the main phone number of the hospital is a phone number that hasn't changed, and people know it almost generationally and will call that number for all sorts of things, not even always directly related to direct care. So we might have somebody call and, ask about a patient, but there also may be a transportation issue, as an example. Some of the places where we have experience, they may have the ability to get that person right over to a company that can help with transportation. Mm-hmm. Or if it's clear, if it's clear to one of the folks on the phone speaking with the patient that there's a food security issue, they may be able to get them directly connected to the food bank. But we all understand that community hospitals in that community can be a large city neighborhood or the only hospital for 100 miles around. Those community hospitals are central places where people go to for kind of their well-being and health. And the more that we can solve some of those equity problems right there kind of on the front door and give people some better access, the better off we'll be.
Mm-hmm, absolutely.
Yeah. And you're going to go to the next slide.
Yeah,
there.
I hit the wrong button. My apologies.
Not at all. And, Gina touched a lot about data and people and technology. And really, that's the way we think about it, is using the technology to get the most out of the people. If you think really broadly about people that are calling into healthcare systems, there's usually two fairly large groups. One group is calling with something that's a fairly routine request where they could be immediately gotten into a place where they can get the information they need, whether it's an appointment, whether it's to give information. Sometimes they're returning phone calls, where they just need to give information to the system that will assist in not having a claim be denied. Other people really need to speak with somebody. So if we can have the right blend, then we can set up situations where people that really need help are getting help from people that are a little bit less burdened, a little bit less harried, and a little bit less in a rush. And those people can also gather information to help, advance health equity by having more data. And the other group can have an experience where they have a seamless, modern ability to interact with the system and reduce waste on that side.
Absolutely.
So, kind of speaking ahead of the slides a little bit, but really that blend between live agents and automation is what we're really talking about. There are things that technology can do almost ironically in terms of getting data and information that people have a hard time doing it. So we work with a great system, the University of Washington Medicine. They're really progressive. They really, really care. It's a really committed group that wants to eliminate any lack of equity wherever they can. So they try to do a lot of surveying with their base. Who is it that's calling, demographic information, other pieces of information that can then inform how they provide care. What they found was agents weren't comfortable asking the questions. And sometimes if you ask demographic questions and then move into, so where would you like an appointment? People would go, okay, am I not getting the appointment I want because of something I said in the other? So they really were challenged by that and found that by letting an automated kind of AI-driven system conversationally ask people some questions before they got to the agent, they were able to get a lot more and a lot more valid information before they even got to the agent. So it was interesting because it was a little bit ironic in some ways. Yeah. And this is just to say that it's sort of happening still, 2/3 of people still call. no matter how many hundreds of millions of dollars are spent on trying to get people to interact only on the portal and all the effort around that, you still have a situation where lots and lots of people still call and will continue to call because they're comfortable, because they feel like that's the only, what they're used to, or they don't have a computer. All the reasons are still there and will be there for a long time. So rather than only trying to move people away from calling, putting some investment into thinking about how to handle those calls and maximize the benefit for both the patient and the system is a big part of the future and making things a better, equitable, and ultimately profitable experience for the system. So it's really all about humanizing it. If you can have people have the experience they want to have, they're going to be a lot more happy and successful. So people that have a simple question, they don't really necessarily want to listen to an operator or an agent, say, hey, thanks for calling, a big preamble before they simply say medical records, for instance. Or if you just want to set an appointment and your technology comfortable, just being able to do that would be great. Other people really want that personal experience or really feel like they have questions that they need to ask to a person. So creating that ability to have both available in a sustainable and repeatable way is really a great way to do it. And really partnering with both patients and providers to understand what people really want. One of the things that we had come up a lot during COVID, because of course, all of the visiting of patients in hospitals were completely changed, disrupted, eliminated, however you would want to refer to it. We have the ability for people to just call and be transferred right to their loved one's bedside, which is great. But in the days where you're visiting your patient, you might stop by the nurse's station and say, hey, how are they really doing? And you don't have that ability during COVID. So we had a lot of systems that we worked with that kind of added the ability to not just get to the patient, but get to the nurse's station and get to a provider that can give you an update on the loved ones. And that really just made it a much more human experience.
So wrapping it up with, the journey that we've taken today, talking about health equity and how we as revenue cycle leaders can impact the process and be a part of the solution to solving for health equity, leveraging technology where available to also solve. It's important to know that there is technology out there that can help us today protect our revenue by capturing, storing, and routing some critically important information. How many times do you get a phone call from an insurance company calling back to give you an authorization number for your case managers who are working to get that resolved? Not everybody works, online via portal, so you don't always have access to get that information. That information can be captured telephonically, transferred into a report that can either be worked or, if you're highly sophisticated, integrated directly into your system. Patients can call in, update demographics. Again, that information can be captured. It can be a report that's either worked or integrated directly into the system. So we have got to be smarter revenue cycle leaders, leveraging every ounce of technology that we can to maximize those ROIs and support true health equity across all of the services that we have to offer our communities. And it starts by understanding what the needs are and how we can solve the problem and to what extent we're going to solve that problem, and then driving those solutions. Well, that's all that I have today. Scott, do you have any other information regarding health equity you want to share before we move into the question and answers?
No, we only have a few minutes left. Yeah, I'd love to hear from the audience of any questions that you may have that we can answer or expand upon.
Sure. At this time, I'd like to invite those listening to enter your questions in the Q&A box located on your computer screens. And I think I have a question here. Do you feel like the voice channel is one that can be capitalized on to support health disparity elimination?
Absolutely. I'm convinced of it.
Great. And then also, let's see, will eliminating bias and other sources of inequity in our healthcare system based on race or ethnicity, age, gender, etc., lead to better health outcomes?
Oh, absolutely. I mean, I think that whatever we can do to ensure that those health disparities are eliminated and that we are caring and educating to the individual and meeting them where they need to be met, that we absolutely can. Yes.
Well, thank you. And with that, we have reached the conclusion of today's webinar. I'd like to thank our speakers, Scott and Gina, for presenting and Parlance for sponsoring. We hope you have found the presentation informative. Thank you for your participation and have a great day.